So one of the reasons that we are able to make some predictions about KAT6A, although we need a lot more information from a lot more patients, is that we know about other diseases that work in the same complex and what they look like and what their clinical features are. So you can see right below KAT6A, there are a couple of, there are 3 different proteins actually, and all 3 of those proteins are known to cause these epigenetic diseases. That they all cause certain facial features, developmental disabilities, and things that are different and unique, but also similar to KAT6A in many ways. When Dr. Bjornson talks, you'll hear a little bit more about that, but this is some of the reasons why we think that we can possibly at some point use similar therapies to address all of these disorders, is because they work together in complex, and many of the features that we're targeting are not exactly the same, but are certainly similar. So, we've talked about what KAT6A is and what it does in the body, and you all know that the reason that you're here is that somebody has told you that your child has a problem with KAT6A. So how did this problem happen? What does that mean? So KAT6A is a genetic disorder, which means that in the gene that encodes the protein KAT6A, something happened in your child that gene wasn't correct. The code for that gene was changed and not correct. So how does that happen? Well, there are 2 different ways. So in theory, KAT6A problems are what we call autosomal dominant, which means that if one parent has this disease, has KAT6A syndrome, then there's a 50% chance that any child they have will also have this syndrome. However, we do not, at this time, know of any cases where this has been actually how this has been passed down. Most of the time, what happens is inside, when the baby is developing inside mom, something happens inside the baby only that makes a change in this KAT6A, and that's what we call de novo. De novo meaning new. It happens newly in the baby. So all of the children with KAT6A that we know of currently have this possibility to pass it down to their offspring, but as far as we know, it did not come from any parents. Yes, go ahead.
I think we just saw right on the Facebook study that there's a family in Japan with three of the 4 children in the family have the KAT6A mutation apparently. So
interesting.
Yeah, that was a pretty recent.
So that something happens there. And what has happened there is one of the parents carries that mutation in their germ cells. So either the sperm of the dad or the eggs of the mom. So we always tell families that on average, if you have had one child with KAT6A, you have about a 1 to 2% risk. And what that means is that 1 to 2% of people have the mutation in their germ cells, but the rest of the people have no chance of passing it along. So most of everyone, 99%, 98% of people don't have that, but 1 to 2%. And that's, we often see one in one family.
Oh no, that's great.
In your germ cell, either sperm or egg.
But not everywhere in that person's body, because otherwise they would have the syndrome. Okay?
Parents have been tested and came back negative.
So even if the parents are tested, even if the parents are tested, they can still carry mutation in the cells that they don't have access to. Do you understand? So basically the risk is always that 1 to 2%, but that means that 90% of parents, if they don't carry it, are not going to have another child with KAT6. It's a very minuscule problem, but what we see is there are occasional families that have multiple kids. But it's
possible to test all the cells in the body and make sure every cell is free of inflammation.
To follow a question on that, so if you have one child that has KAT6A and you have another child that is normal, is there a possibility that the normal child carries?
No.
No.
No. This is the schematic of the KAT6A gene. So it's located on part of chromosome 8. There have been some cases where there's a part of chromosome 8 that gets deleted. So the whole KAT6A gene is missing. And most of the other cases that we know of occurs because of a change in the code of the actual KAT6A gene. So it can occur if a whole section of this chromosome is deleted, but it more commonly occurs because you just change one letter in the DNA that then causes that protein to be dysfunctional. So, we've talked about what KAT6A does and how a problem in this gene could happen. So, what does it look like? So, as you all know, thus far, there are only a few reported cases, which means cases that get published in the literature. You all are here, and most of you have not been published in the literature, so we know there are many, many more cases than what are published, but the way that the whole community learns about things is cases being published in the literature, and so far, there are only a few. What we do know is that we know both from the cases published in the literature and cases that we have seen in clinic, that there are similarities of KAT6A to other histone modifier epigenetic disorders. So those other disorders from that picture I showed back there, they have similarities to KAT6A. So we think we might be able to make some predictions about KAT6A from those, as well as from the actual KAT6A cases that we've seen. So this syndrome was first reported in 2015, so that's why we say it's really very, very new. Everyone who has been reported thus far are children. It is very possible and likely that there are adults out there with this syndrome, but we just have not diagnosed them. Yes?
On our Facebook group, there are people who are in their 20s.
Yes. So we are sure that there are adults, probably even older than that too, with this syndrome. But adults don't go and get genetic testing as frequently as children do. So it's very, very often in these genetic disorders that children get reported first, and then adults get found and reported later. And again, just like we said before, obviously there's a family, and that's why these Facebook groups and you guys knowing each other is so great, because that's the way to get more access to more patients. Because again, thus far, everybody reported has been de novo mutations, so new in the child, but clearly there are cases of germ cell mutations and other things being passed down to multiple children in the same family. There are some features of KAT6A that in the patients who have been reported are nearly universal. So we're pretty confident in saying, yes, these are the features, the cardinal core features of this disorder that we know of so far. Then there are some features that seem to be related. So present in only a few of the patients that have been reported with KAT6A, but certainly present more than you would see in all the general population without the KAT6A mutation. And so those we kind of say, we need more information and more patients to say how closely is this related. So talking first about the features that are considered to be more universal or at least very common. So the first one is hypotonia. So hypotonia means low muscle tone. So this is sort of what people are talking about. You think of it as like a floppy baby. This seems to be, in KAT6A, it seems to be most present in infancy. So the low muscle tone is most obvious in these kids when they are newborn babies. Although a lot of times we know that it persists much longer than that. We think that most of the low tone is obvious what we call axially, which means in the trunk, the neck, the hips, the center of the body, more than in the extremities, the arms and the legs. And in fact, the arms and the legs can at times, in some reports, be very tight as opposed to very loose. But almost universally, that center of the body, that core, is very loose. The next universal feature that we are familiar with is feeding problems. So these feeding problems are probably very related to that hypotonia that we just discussed, okay? Because we know that kids get very poor oral-motor coordination, which means their ability to suck, chew, swallow in a coordinated manner that allows them to eat is very, very poor. Many children, because of this, end up needing tube feedings, whether that's a permanent tube like a G tube or a temporary tube like an NG tube. Many, many kids need feeding by tube methods at some point in their lives. And then reflux is very common as well. All of these things can be related to that low muscle tone, but it seems that this is prevalent enough to be an independent issue that is a feature of KAT6A. Congenital heart disease is also something that is seen very, very, very commonly, again, nearly universally in this disease. It is not necessarily or even usually some of the more severe congenital heart diseases. Usually it has to do with defects of the septum, which is the wall that separates the chambers of the heart. So you could have an atrial septal defect, a ventricular septal defect. Both of these, and even these two together, have all been reported with KAT6A. Other congenital heart disease is a patent ductus arteriosus, which just means that the blood vessel that's present for babies in utero doesn't close up the way it should in patients with KAT6A, or patent foramen ovale. There have been other congenital heart diseases reported, but not frequently. These are the most common ones that have been reported. Eye problems. So again, a lot of this also gets back to that hypotonia. So, you'll see that these things are very, very related to just general problems in the brain. So very, very commonly, these kids have one or both eyes with strabismus, which is otherwise known as a lazy eye. They can have ptosis, which ptosis means their eyelids droop down onto their eye. And then lots of other vision issues, nearsightedness, cortical visual impairment, other sort of vision issues have been reported, but certainly the strabismus and the ptosis are very common. Skull abnormalities is another one. So craniosynostosis means the skull bones in your head fuse too early. So, with all babies, they're supposed to have these soft spots. And a lot of times, our kids with KAT6A, they don't have those soft spots the way they are supposed to be. Their skull bones got completely fused before they were supposed to, which can create abnormal head shape and have to lead to surgery. Microcephaly is also commonly reported, which is a small head. A lot of the reports talk about distinctive facial features in this disorder. So things that have been talked about are what we call bitemporal narrowing, which means that this area here on the sides of your forehead are more narrow in these kids than in other kids. A very wide and bulbous nose. And then several other features have been reported. Another one that's really common is this triangular or tented mouth. And again, this can come with a host of other things, but these are some of the ones that are very, very commonly seen. And as you can see in pictures, and then looking out amongst yourselves and your children too, certainly all of your children look like you in different ways. They look like their mom and dad, but they also have similarities to each other that are very different than the familial look that they inherited. And then probably the most common, most universal, biggest feature that we've seen is this global developmental delay. So when we say global developmental delay, what we mean is developmental delay in most or all areas of development. So gross motor delay is seen very commonly, meaning they're late to sit, crawl, walk, all of those things like that. This is probably twofold. It's probably partially related to brain disease and partially related to the hypotonia or the low muscle tone. Then intellectual disability is reported universally in this disease. So most of the cases that have been reported are moderate to severe intellectual disability, although there have been a few kids who have been on the mild end. And then as part of the intellectual disability is a prominent language and speech impairment. So a large number of KAT6A kids are completely nonverbal, or if they do have words, their words are very often even behind what their intellectual disability would say their capacity is. So their language is their toughest skill, more so than a lot of their other problem-solving skills. So then we get into some of the less common or possibly associated features that are reported. So one is small birth size. So a lot of these kids are reported to be small at birth compared to what their gestational age would predict. So full-term babies being a lot smaller and looking like preemie babies. Again, this is not universal, but it's been reported in more babies than you would expect with KAT6A. Postnatal or after birth slow growth has also been reported, but this is a lot more inconsistent. Perinatal complications around the time of birth are very common. These may also be related to that hypotonia issue. But a lot of kids with KAT6A are reported to have to be born by emergent C-section. A lot of them were in breech positions. Many needed NICU admissions for some help with breathing or feeding or things like that. Again, much more commonly than you'd expect. Seizures. Seizures do not seem to be common in this disorder, but again, more prevalent than you see in the general population. But when we have seen seizures with KAT6A, they've been many, many different types. So anything from infantile spasms, which is a very severe early kind of seizure, to more common types of seizures later on in childhood. So specific behavioral features. So the answer is we have no idea. So there have been a case or two reported with who are reported to have autism. There may be an anxiety component to this. There may be other specific phenotypes, but the answer is there just hasn't been anything on it, so we don't know. We know that there's going to be the global developmental delay, and we suspect that there's going to be speech and language more so than other streams of development. But as far as behavioral phenotypes or more specific cognitive phenotypes than that, we just don't have the information yet. Sleep disturbances. So there have been a lot of sleep apnea reports. Could this be hypotonia? Yes, absolutely. And then just sleep cycle disturbances. Really, really hard time getting these kids to follow a normal sleeping pattern and sleeping through the night. How common is this going to be in this disorder? We don't know yet, but it has certainly been reported. Immune system irregularities are something we know from other epigenetic conditions that are, theoretically related to KAT6A. Some of the cases have reported frequent ear infections and upper respiratory infections in these kids. One case is reported with frank neutropenia, which is a dangerous kind of immune system irregularity, but the jury is still out on this as well as to how common this is and whether or not it's really a problematic feature of this disease. Dental abnormalities, again, common in other epigenetic conditions, have been reported. A whole host of things needs to be further delineated. Hand abnormalities. These are minor things, but lots of things reported with these kids. Curved fingers, that's what clinodactyly is. Brachydactyly is short fingers. A single palmar crease on the hand. Again, mild things, but things that we're not sure how related and how much we see in KAT6A versus other things. And then brain MRI abnormalities. Many of these kids have had a brain MRI. Many are normal, many are abnormal. All the ones that are abnormal seem to be abnormal in many different ways, and not totally clear how the abnormalities correlate to the disease, especially when we're talking about that difficult birth thing with the emergency C-section and stuff. It's unclear to say how much of these MRI abnormalities have to do with that, with a difficult birth and things that happen related to that versus how much they have to do with the underlying disorder. So more data needs to be collected on that as well. And so the bottom line is we have to learn from you all. So you all are the best sources of information to tell us what is common in KAT6A and what's not, and what's a part of the core disease and what are just other things that may or may not happen. We need to draw, like I said, from other similar epigenetic syndromes and find out how much overlap and how much difference there is between KAT6A and these. We need to look at the patients already published. And again, we learn most from you all. So thank you for your time. And I can take a few questions and then we'll move on, and I can of course take questions later too. Yes?
I think another thing we were curious to find out is if there are issues around blood sugar and sort of need to persistently snack and craving of carbohydrates, because it sounds like there might be something that other families are experiencing.
So that's a wonderful question. There isn't anything out there currently about that, but certainly that's something that we see again in other these epigenetic conditions that are related to KAT6A, that they can drop their blood sugar more easily. Sometimes that can have to do with the feeding problem. There may be something more intrinsic and metabolic going on. And my guess is that Dr. Kelly is going to probably touch on that a little bit also. Yes?
So in regards to birth defects,
Okay.
there's been a pretty wide range of birth defects. Some kids have some kids have none, and then there's kids like Savannah who have a lot. How does that happen? What causes the differences in birth defects?
Birth defects as far as different organ systems and body parts that are abnormal at birth. So that can be caused by a number of things. So again, there have been a number of those reported with KAT6A, but just like you said, some here, some there, none here, and so it's unclear which parts are going to be a feature of this syndrome. But there are also parts that we know about this syndrome that can be related. So that whole hypotonia, I know I keep coming back to that, but if you're inside in utero, if you're in mama's belly and you are hypotonic, you don't move around as much. And when you don't move around as much in there, it can actually cause some birth defects, okay? Because you're kind of stuck in one position, and that can cause deformities in the extremities and things like that. So the answer is we're really not clear what's what But certainly, like I said, the congenital heart disease, the skull abnormalities, those kind of things are definitely going to prove to be a cardinal feature of this disorder. And everything else we got to figure out, is it random in this one kid, or is it something that we have to sort of look out for, even though it's not the most common feature of this disorder?
Thank you.
Of course, yes.
So I'm Cora's mom. She's the youngest diagnosed as we know today. She'll be 10 months next week, and I'm interested in the hypotonia because what I've been told is that she has hypertonia, but I'm not sure how accurate that is because she has physical therapy and all that stuff. So she has her trunk support. She's always had really tense muscles.
Yes.
If I lay her down, she'll like hold her head up from a really young age. So she can sit up really well. That's the only like motor skill that she has. Like she doesn't roll over, she doesn't crawl, any of that stuff. And her physical therapist says that like she's compensating. Like she says that she's not using the right muscles to sit up. So I didn't know if like I've been given a wrong information in that, and it's actually hypertonia and she's just compensating. You know what I'm saying?
Yes.
So that's kind of my one question. And then my other thing was I didn't know about like the traumatic birth being like a thing that KAT6A kids had, because I went into like my water broke naturally with her, but then I had a 20-hour labor and she was stuck under my pelvis, and it was like a traumatic situation eventually. Like I had to be induced eventually, and it took a really long time. So I didn't know if like, I thought it was just like, oh, different baby, different, things, but it might be related to her disorder. That's, yeah.
Yes, so addressing the second question first, yes, it may be related, okay? And again, not to keep harping on the same things, but that low muscle tone, right? So if if you're not very tight, if you have low muscle tone, it makes it a lot harder to get through the birth canal and to do everything that the baby needs to do to get through the birthing process. And so is that the only reason that we're seeing these increasing difficult births? We don't know yet, but that could certainly be related. But either way, it does seem that the KAT6A kids have more of the difficult births than the typically developing population. As far as the hypotonia versus hypertonia,